Hello, good afternoon, doctors. On
Good
behalf of
afternoon.
Hetero Healthcare, I welcome you to this webinar on Carbetocin in action. Doctor, at Hetero Healthcare, we have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have got 300 plus products in our portfolio and our presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, API, and FDFs in the world. We are Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India. We have a wide product range encompassing multiple specialties, and we are pioneering in quality and innovation. We have a distinction of bringing 4 biosimilar products to market within 5 years of initiation. Carbetocin, we know, is a drug which is approved and used for prophylactic management of PPH. And PPH, as you all will agree with me, is a condition which, as you say, expect unexpected can come to any patient at any point of time. This condition is best to be discussed, read, rather than seen. And although there are many papers and guidelines of use of carbetocin, we always like to have our own doctor's experience and insights into PPH and management by carbetocin. For that, today we have got renowned Dr. Rashmi Ahuja with us. Welcome, madam. Dr. Rashmi Ahuja is MBBS, MD,
Good
DNB,
afternoon.
FICG. Madam is Senior Consultant, Matritwa Hospital, New Delhi, practicing obstetrician and gynecology in Faridabad. Experience of more than 14 years in obstetrics and gynecology. Madam is member of Faridabad Obstetric and Gynec Society, with special interest in high-risk obstetrics, ultrasonography, and gynec endoscopic surgeries. Welcome, madam, once again, and over the session to you.
Thank you, sir.
Thank you.
Today I'll be discussing a topic that is PPH. That is a very a, a nightmare for everyone, and actually having an incidence of 3 to 5% if 100% women deliver normally or having a cesarean section. PPH has actually a blood loss more than 500 ml in cases of normal delivery and more than 1000 ml following a cesarean section. Actually, if a patient is anemic, then the blood loss less than even 500 ml or 1000 ml can be labeled as PPH. If it deteriorates the pulse, BP, vitals of the woman, then that is also labeled as a PPH. So it is common and can occur even in women who are not at risk. It is very unpredictable, and any woman who is having a normal labor, normal delivery can suddenly land up in PPH. PPH is the leading cause of maternal mortality, and in low income settings, it is comparatively more common. So it is accounting for 35% of all maternal deaths, but in cases of total number of deliveries, the incidence is 3 to 5%. MMR in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. The global PPH incidence have been 14 million women suffer from PPH, and the incidence is 2 to 4% after normal delivery and 6% after cesarean section. 38% of maternal deaths are due to PPH in India, and 25.7% of global deaths take place in India, two-thirds being attributed to PPH. India has an unexpectedly high maternal death rate. The main reason being anemia in India is very prevalent. So this is the main reason. 540 per 1 lakh live births is the incidence. Etiology of PPH, the 4 T's, this is always to be remembered, and the most common and most important of all is the tone. That is, the uterus becomes atonic suddenly after the fetus is delivered, after the placenta is delivered. So tonicity, that is the uterine atony, is the most common cause of PPH. Second is thrombin, that is if a patient has a coagulation defect, the PT-INR is deranged, the platelet count is low, then coagulability can be a reason. Trauma, like if there are cervical tear, vaginal tear, or a deep episiotomy, or in cases of retained tissue, like if there are retained products of conception or the placenta is retained inside, then this can lead to PPH. The most common B is atonic PPH. Clinical findings, what are the clinical findings? There can be there can be changes in the vitals, like the pulse, the tachycardia will be there, hypotension will be there, loss of uterine contractions, and there will be continuous pouring of blood through the vagina. So it can be of three degrees. It can be mild, moderate, or severe. In cases of mild, the blood loss will be up to 1000 ml, that is 10 to 15% of the total blood volume of the mother. Uh, uh, if 10 to 15%, then it will be labeled as a compensated PPH. In cases of mild, it will be 1 to 1.5 liters. In cases of moderate, it will be 1.5 to 2 liters. And in cases of severe, it will be 2 to 3 liters. And in all the cases, the blood pressure will start falling after there is 1 to 1.5 liter of blood loss. So blood pressure will start falling after this. And the mainly symptoms and sign will be, in the compensated case, only tachycardia will be there. Then in cases of mild, tachycardia as well as fall in BP will be noted. And in cases of moderate, oligouria, and cases of severe, anuria will land up. Next slide. Diagnosing. How will you diagnose PPH? But first of all, you should keep in mind what is normal blood loss and what is exceptional, what is more than normal. So rapid assessment of the patient status, presence of tachycardia and hypotension, that is a fall in blood pressure, and assessment of vital signs and blood loss. Assessment examination at the time of hemorrhage, assessment of the entire genital tract for lacerations, hematomas, or signs of uterine rupture. Manual examination for retained products. Assessment with bedside ultrasound to check if the uterus is non-contracted or if there are any retained bits within the placenta, within the uterus. And evaluation of the uterus to check for uterine inversion. Uterine inversion mainly leads to a condition of shock, and PPH might not be there, but you have to evaluate if the fall in blood pressure and pulse is because of this. Laboratory and assessment, CBC should be simultaneously sent, as well as blood group should be sent, and coagulation studies to rule out the thrombin part of PPH. Approach towards PPH, first of all, you have to deal with the poor uterine tone. First, the most common reason is the atonicity. So you will do an abdominal palpation. Uterus will feel relaxed, boggy, and soft. Fundus may not be well palpable. On investigation, CBC, coagulation profile, urea and electrolytes, and an ultrasound to rule out products only. The management will be mainly uterotonic agent, that is oxytocics, prostaglandins, or ergot alkaloids. They are the mainstay to prevent atonicity. Uterine balloon tamponade will be helpful when these uterotonics are they fail, or they are not able to control the bleeding. So, and one more thing, that is the hemostasis algorithm, that is stepwise. Uh, First of all, we will go with the medical management, and will oxytocics, prostaglandins, ergot alkaloids will be used. Then if it fails, then we can still use tranexamic acid. And if that also fails, then you can go for uterine balloon tamponade. These are all conservative measures. And if still the patient continues to bleed, then you will shift the patient to OT. And in OT, you will go for the stepwise devascularization. And if needed, hysterectomy can be the last procedure to control the bleeding. In cases of tears or trauma, first of all, the patient is to be properly examined under anesthesia to rule out cervical tear, vaginal tears, and they should be properly repaired. If that also fails, then pelvic artery embolization is the final measure that may be of help if these measures are not able to control the bleeding. Retained tissue. In cases of retained placenta and membranes, these are identified during the bimanual examination. So, if you are not able to remove the placenta under normal condition, then anesthesia might have to be given to the patient, and under anesthesia, manual removal can be done. Coagulopathy, in cases of coagulopathy, when the PTNR is deranged, platelet count is low, and the laboratory testing confirmed that there is coagulopathy, then first of all, immediate replacement of the blood and the coagulation factors and platelets, like transfusion of PRP, transfusion of FFP can be done. And only with after trauma or atonic PPH are ruled out, then you can use the surgical method like B-Lynch methods or the uterine compression sutures. Attempt should be made to identify the cause in women who are bleeding. First of all, you have to identify the cause so that you are able to act upon that particular cause only. Next slide. Now we will discuss what are the oxytocics. There are many oxytocics that are available to us. First of all is the oxytocin, that is very commonly used drugs. Then we have prostaglandins. Then we have ergot alkaloids. Now we are discussing here is the new formulation, that is the carbetocin. Carbetocin is the new heat stable combination. As we all know, the main problem with oxytocin is the temperature sensitivity. That is, it has to be stored at 2 to 8 degrees Celsius. If not stored between 2 to 8 degrees Celsius, then it loses its vitality. So it has to be stored between 2 to 8 degrees Celsius. If it is, but if it is not available, just a minute. Sorry for the interruption. Now this newer heat stable product is the carbetocin. Oxytocin and ergot alkaloid should be kept in a refrigerator. Heat stable formulation is currently not available. So previous formulation of carbetocin, they were also used to be stored between 2 to 8 degrees Celsius. Now the resource poor countries like in India, they in the peripheral areas, there are no refrigeration or the maintenance of cold chain is not possible. So we need a better alternative, and which is carbetocin, which is stable at room temperature. It has a shelf life of 24 months. It avoids need for cold chain storage and logistic, and it is provided in a vial. So these are the advantages of carbetocin. What are the uses of eutotonic agent? First of all, eutotonic agent is an agent that will prevent atonic PPH. So what can be the time? When should it be administered? It can be administered at the crowning of the baby's head, but it has to be given in limited dose till the baby is delivered out. Earlier it used to be given at the delivery of the anterior shoulder, but now we deliver it at the end of the second stage of labor. The second stage of labor is after the baby is delivered or following the delivery of the placenta. So what is the prophylactic use? Prophylactic use is the prevention of PPH, and the active management of third stage of labor is the normal procedure that we follow to prevent PPH. And therapeutic use is the management of PPH. If your all the steps that you took to prevent the PPH, they have failed, and now you are landed up, the patient is bleeding, and now you have to manage. So when you need to manage the PPH, then the methods the molecules, the available molecules which are available to you are oxytocin, carbetocin, ergometrin, symptometrin, that is ergometrin plus oxytocin combination, or the misoprostol. Carbetocin is a next generation drug for PPH management. It is a synthetic long acting analog of oxytocin, and oxytocin acts for around 4 to 5 minutes, but carbetocin has a half-life up to 8 minutes, 30 minutes. Therapeutic indication, prevention of PPH due to uterine atony. One vial contains 100 microgram of carbetocin in 1 ml solution, which can be used either for IV use or can IM use. Next slide. Clinical evidences that we have available. There are many studies which are there, and the one we'll be discussing is the carbetocin proved non-inferior to oxytocin. It was a WHO champion trial, in which it was proved that when the study was done, it was non-inferiority, double-blinded randomized controlled trial in which the the effectiveness and safety of carbetocin and oxytocin in the prevention of PPH were compared. 30,000 women across 10 countries, including India, were enrolled in the study, and the outcomes confirmed that carbetocin is non-inferior to oxytocin. So in many countries, it has been labeled as the drug of choice for the prevention of PPH. This this table shows that the efficacy is nearly comparable. The blood loss is also not, there's a big difference. And adverse effects. The adverse effects, they were also comparable. That is 4.9% with carbetocin and 4.7% with oxytocin. So there is no significant difference when we use carbetocin as compared to oxytocin. Next slide. The Cochrane review has confirmed that for women who undergo a cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic eutotonics compared to oxytocin, and carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for the women who have vaginal delivery, and is associated with significant fewer adverse effects. Next slide. So according to the guideline recommendations, the WHO recommend that oxytocin should be used. So oxytocin includes oxytocin, carbetocin, and with misoprostol or ergometrins if either of these is not available. SOGC Canada has after the study was done, so carbetocin they have made as the first line drug for the prevention of PPH, but IV bolus. The New Zealand committee has said that the active management of third stage of labor should be practiced, but prophylactic uterotonics is to be there. Uterotonics include carbetocin also. PIGO suggests carbetocin is one of the recommendations for PPH management. Germany says carbetocin as the first line drug, and France also says as the first line drug as carbetocin only, because these are well developed countries, they have no financial issues with them. But in India, because of the cost factor, we are still using oxytocin as a first line drug, and then carbetocin is a far better drug which can be used in its place. My experience with this carbetocin is in cases I have been earlier I used to work in government medical colleges, and since for last 3 years I have shifted to private practice. The day I shifted to private practice, first of all, the threat that haunted in my dreams was of PPH only. So I I made all the drugs that can be made. I made it sure that all the drugs A to Z which can be used in PPH to be available at my emergency tray. So carbetocin was the first drug that I ensured, because I had heard so much about it from my colleagues that whenever we with carbetocin, ये बिल्कुल हड्डी बन जाता है, कोई चिंता वाली बात नहीं है, कार्बिटोसिन दो दो दो, और बिल्कुल ऐसा कोई सेफ्टी प्रोफाइल बहुत अच्छी है। तो फिर मैंने जब पता करा, पहले मुझे लगा कि कॉस्ट फैक्टर बहुत ज्यादा होगा, बट इट वाज नॉट अ सिग्निफिकेंट डिफरेंस। अगर हम 10 एम्प्यूल्स ऑक्सीटोसिन के दे देते हैं
Yeah,
और
yeah.
एक कार्बिटोसिन देते हैं, तो कोई सिग्निफिकेंट कॉस्ट फैक्टर बीच में नहीं था। तो इसीलिए मैंने कार्बिटोसिन को अपने पास रखा, एंड आई हैव बीन यूजिंग इट। वैसे आई हैव बीन यूजिंग इट ओनली इन हाई रिस्क केसेस। अदरवाइज जब भी मुझे थोड़ा सा भी लगे कि पेशेंट को ब्लड लॉस, इसमें प्रीवियस हिस्ट्री ऑफ पीपीएच है, पेशेंट जो है वो पीआईएच प्रोफाइल है या ट्विन्स है, अनीमिक है, तो उन केसेस में मैं पहले से ही कार्बिटोसिन प्रेफर करती हूँ। और एक भी पेशेंट को आज तक पीपीएच नहीं हुआ है।
Madam, lovely experience. You use the word haddi jaise kadak hote. It describes actual the tonicity and
हाँ,
how
यूट्रस
hard,
बिल्कुल ऐसा हो
yes,
जाता
how
है। जी
hard
जी।
they I mean, in
जी।
my time in the late 70s, we had only oxytocin and methergine. And I was fortunate to see only one case of PPH until now. But I
ओके,
can
ग्रेट।
imagine what it is. We always, it's better to discuss and talk rather than see. And
या
rightly you did, strengthen your PPH tray. That's most important.
या पीपीएच रहे, यस।
And any side effect you saw when you use carbetocin?
नहीं, not yet. I have not seen any side effects. But with oxytocin, I had seen in one patient fluid retention was there. She
Correct,
became
correct, correct,
drowsy and
correct,
she was
correct, correct.
talking irrelevantly when I had given oxytocin for long. So with carbetocin, I have not noticed a single side effect in any of the patients.
Lovely. Okay, we come to the panel questions.
Yes.
I mean, your experience I've already shared. That's no
Yeah.
point to ask.
Yeah. Yes.
Which patient profiles can a doctor anticipate PPH? Although, I mean, it can happen in any patient, but
Yeah,
anticipate.
it can happen in any
Yeah,
patient.
correct. That's
Any
correct.
patient can be,
Absolutely.
any normal patient can land up in
Correct,
PPH,
correct,
which
correct,
is
correct.
totally unpredictable. But still, there are certain high risk factors in which we get prepared for PPH, like in cases of twin pregnancy, whenever there is uterine overdistension, like in cases of
Okay,
polyhydramnios,
okay.
previous history of PPH, or when there is adherent placenta, there are chances that the patient will placenta will not deliver. Like in case of placenta accreta
Agreed.
syndrome, then they after these cesarean sections, placenta accreta has become very common. And in cases of anemic patients, PIH, PIH, these are the patients in which there is high risk of PPH.
Patients suffering from diabetes, do they have high, I mean,
If a
is
patient with diabetes has
diabetes?
over big
Old
size
distance,
BP
okay.
and over distended uterus, then
So,
there is risk of PPH. Otherwise, normal GDM patient controlled on diet, controlled on insulin, they normally don't have PPH.
so any factor which can increase, which can reduce the tone or increase the size is patient will be prone for PPH. Right.
Actually, right.
When would you prefer carbetocin or oxytocin? Now, both being available. I mean, in private practice, straight away, even will go to carbetocin. Why keep it reserved? But
Yeah, actually,
otherwise,
the main reason is that oxytocin lasts, the effect of oxytocin lasts for few minutes only, but carbetocin effect lasts for long, for nearly 30 to 40 minutes.
right.
So I prefer, because if the patient has a tendency, the patient gave history that I had PPH in my last pregnancy and the
Okay.
uterus is twins with
Yeah,
polyhydramnios, then I prefer using carbetocin because it will have a prolonged effect till the time I complete my surgery, till the time I am able to shift the patient, observe. Then I prefer carbetocin because oxytocin need to be given in maintenance maintenance doses also. For next 2 to 3 fluids that I give, I have to give oxytocin. But if I have given carbetocin to once only, then I don't need to give oxytocin more and more in the further maintenance fluids.
And especially in patients with high risk of PPH, I mean, carbetocin could be straight away preferred over
Yeah, I can use.
oxytocin.
Yeah, I do prefer it to be
Yes,
used
yes, yes.
directly.
Correct.
Yeah.
Can we use carbetocin in case of retained placenta? Your experience, madam.
Yes, in cases of retained placenta, it is a very good drug. When injected directly into the umbilical vein, it goes to the uterine musculature and
Hmm.
brings about contraction without entering into the systemic circulation, without causing any problem. It causes contraction of the myometrium and helps in the separation
Expulsion.
of the retained placenta.
Okay.
It is a very good drug and should be preferred whenever there is retained placenta.
Placenta.
It should be preferred over oxytocin.
Another question. This is another question which comes. Rh negative mothers.
In cases of Rh negative mothers, carbetocin is totally safe. There is
Safe.
no contraindication to use of
Correct,
carbetocin.
correct, correct.
Actually, ergot alkaloids are avoided. Otherwise, carbetocin is not contraindicated in Rh negative mothers. We can
Uh,
definitely use it.
and Rh negative mothers, if she bleeds, then again getting blood, especially in the interiors, periphery, it could be, I mean, it may not be so easy to get.
Yes,
Yes.
yes.
Can a doctor use carbetocin for prevention if oxytocin is used for labor induction? Most of them would
Yes,
be using yes.
yes, oxytocin, if used for labor induction, then it has a short life. It gets used up in blood in 2 to 8
Metabolized.
minutes. So carbetocin can definitely be used. Normally, oxytocin is used for labor induction, for labor augmentation,
Yes,
and
yes, yes.
oxytocin is given continuously during the
Correct.
course of labor. So if the patient delivers, we can use carbetocin. There is no problem, or there is no interaction of the both the
Interaction.
drugs if
You
used
can use.
simultaneously.
In which you generally prefer IV route, you said. But any specific place for IM route?
In case like a patient with severe anemia,
Ah,
when I need to have a effect immediately, when
ah,
even a slightest amount of blood loss may
yeah, yeah.
deteriorate the vitals of the patient, then I will prefer a IV route.
IV route.
And when I need a prolonged effect, then I will prefer IM.
Madam, what is your take on the pre-filled syringes of carbetocin, which are to
Okay.
be used only IV?
नहीं देखिए एक्चुअली आप आई वोंट प्रेफर अ प्रीफिल्ड सिरिंज बिकॉज आई हैव ऑलवेज यूज कार्बिटोसिन intravenously and I have diluted it before giving it.
Oh, yeah,
So a
yeah.
prefilled syringe will not be of help to
Yeah,
me.
yeah, yeah. ये
It will
डाइल्यूशन
actually
तो हो
be
ही
a
नहीं
waste.
सकते या डाइल्यूशन नहीं कर सकते करेक्ट
हाँ, उसमें डाइल्यूट नहीं कर सकते और मैंने हमेशा डाइल्यूट करके ही यूज किया है। एक्चुअली बस थोड़ा सा माइंडसेट में था कि कहीं कोई दिक्कत ना हो जाए तो सेफ होने के लिए।
एंड
अदरवाइज
ये why simply take chance ना
या व्हाई
and if
सिंपली
that if
टेक
yeah if dilute also gives you the same effect then
Yeah,
why
it's giving
yeah
the same effect. I just dilute it to 5 ml or 8 ml and then I
very
give
good.
slowly. So there was no difference in the effect. And I normally for all the IV drugs, I prefer because I don't have a ICU at my setup. So
Correct.
I give all the
No, no.
drugs being
And
diluted.
pehle there will be one problem of PPH and why have another thing, I mean, it's very correct.
Yes, yes.
Yes. And we don't know
So,
embolus, we don't know all those things finally.
yes.
If the patient is not responding adequately with carbetocin, what
Yeah.
other additional uterotonics we would use?
If the patient is not responding adequately with carbetocin, then we can go, switch over to oxytocin. We can give up to 60 to 80 international units of
Oh,
oxytocin can be given that are safe. And others are misoprostol is a safe drug that is also room temperature sensitive, room temperature stable. We
stable.
can use misoprostol and carboprost can also be used. That is given
Prostaglandins,
intramuscularly
yes.
and one dose will usually brings about tonic contractions.
I mean, you always said this guy use advantages of
Yes,
yes.
carbetocin is better over oxytocin as it is heat stable.
Correct.
So it can be easily provided to the centers in the periphery of India,
Exactly,
like in
exactly.
the like in rural settings. Carbetocin will be a boon if provided by the government, made free of cost, available to
Correct,
these
correct,
centers.
correct.
Then it will be a very good thing
Absolutely,
because yeah, many people are not actually aware. Actually, the deliveries are being conducted by staff nurses and
absolutely.
lower
Yeah, yeah.
cadre people who are not aware what are the temperature storing conditions of
Yeah, correct,
oxytocin.
correct.
Yeah, so it
Uh,
loses its efficacy.
And power outage is another thing. I mean, even in places like Mumbai, Delhi, there are a lot of power outages. In the interior, we don't know what the situation is actually. And
Yes, yes.
oxytocin efficacy will be reduced.
And
Otherwise,
now actually a bond has been made for all the MBBS and all the fee for the PG people. They are going to rural services. So actually, and people are ready to bang on them. If a PPH or if the patient dies, then they
we know what it
then
is.
they are also bound to die. That some problem might be there.
Yes. Yeah,
So if
I mean,
carbetocin is made available free of cost by government of India, then
yeah,
it will
yeah.
be a boon to the doctor.
Everybody, yes. And methyl alcohol,
Misoprostol, yeah.
misoprostol, yeah.
Misoprostol is actually available in the tablet form. It has to be given vaginally or rectally. So it is not a immediately fast acting drug. Carbetocin is given IV,
Yeah,
so it
yeah,
is
yeah.
actually acts
Okay.
very fast. Carboprost is always given to be IM, and the main problem with carboprost, whenever in 100% of the
Asthmatics,
patients,
yes.
vomiting and vomiting. All the patients vomit out whenever carboprost is given.
And their golden moment, time they start vomiting, I mean, that's good.
Yes, all the patients vomit, and carboprost also. I normally it is a PGF2 analog, so not
Yeah.
more than 3-4 doses can be given. Maximum is 3-4 doses.
And asthmatics again, we don't know,
Yeah,
no?
we don't cannot be used in
Correct,
bronchial
correct,
asthma
correct.
patient, and ergometrine cannot be given in cases of hypertensive
Hypertension, yes,
patients.
correct,
Yeah, we
correct,
cannot
correct.
use, but carbetocin can be used in all these patients.
Should carbetocin be kept as a reserve drug, or it should be, I mean, you already answered, it should be a first line
It
therapy.
should be
It
used
should
as
be
a
made
first
as
line
first
drug.
line.
Definitely.
How would you compare adverse effect profile? I mean, we have discussed this, but otherwise, I suppose the only thing there is no water retention issue with carbetocin we have used. Maybe a single
Yes,
dose is
yes.
used.
There's no water retention issue. Actually, I have given only a single dose of
Single
carbetocin
dose.
in
Yes,
all
that's
the
what it is
patients.
recommended. Yes.
So there was no side effects in the
Yes.
patient I have observed. Not, no side effects.
Your one line on this carbetocin to conclude.
I would conclude that it is the best drug available to doctors, and the cost, as the cost has been reduced dramatically,
Yes,
so it
yes.
has become a boon to
Approach, yes,
gynecologists,
yes.
and it
Available.
is a very, very good drug which should be used by all and should be at least
Correct.
tried at least so that you become confident and you agree to this that carbetocin should be a first line drug for the prevention of PPH.
That will be all, madam, from our side. Thank you so much for your insights, madam. It was lovely. I'm sure the people who attended will benefit out of it. Thank you so much. It was
Thank you,
lovely,
doctor.
listening, getting insights on PPH, because
Yeah.
we have seen patients long time back now. Good.
No, actually, PPH is still a nightmare
I
for
know. Yeah, yeah,
everyone.
yeah, yeah, yeah,
Everyone.
yeah, yeah, yeah.
I have kept everything the for conservative method, not only the condom catheter, the uterine balloon tamponade, the Bakri's balloon, everything available in the
Baapre.
conferences. The rest
Absolutely.
of the rare thing I have kept with me because I know I don't have an ICU. I have to be prepared for this
And
PPH.
expect the unexpected is a golden rule in our practice.
Yes,
Yes.
yes, yes.
Thank you. And thanks all the participating doctors for taking your time and attending. Thanks marketing team Hitro, thanks field people, and last but not the least, thank you Jayant, IT support for this meeting. Thanks all of you. Signing off. Once again, thank you so much, madam. It was a pleasure.
Thank
Thank
you,
you.
sir. Thank
Thank
you.
you. Can we sign off, Jayant?
Yes.
We'll again meet at 3:30.
Yeah, okay.